cure asthma, or does he just bring it under control and give a good quality of life to the patient? So we need to readjust our goals of treatment towards improving quality of life quotient also. For all of us who are on the international circuit, these are two of my close friends, Kenny and Brian, and I am very much in agreement with this sleep goal criteria that they've kind of put across to the world, and we are hoping that it will come across. You can all read about this criteria. They've elaborated the criteria into different things about the sleep goal. And it also incorporates the AHI, it incorporates the BMI, it incorporates pressure issues whereby the systolic and the diastolic pressures would go down to a certain level. So when you have a criteria like this, it's a little bit more definitive rather than just looking at one AHI as an index. So I'm very much in agreement with both of these, and I also agree with this particular statement that both Kenny and Brian make, that it's just not about the AHI. When we put up a sleep goal criteria, we know that we are making it a little bit more complicated. But I guess making it a little bit more complicated is more objective rather than just relying on an AHI to tell us whether my surgery has succeeded or failed. So we want to jumpstart this kind of a discussion with different indices to help improve the surgical success rates. So when it comes to this now, it's very clear, the controversy has been laid to rest, that AHI is definitely not any limitation for us to operate on a patient. Neither is it a kind of an indicator which tells us that it is successful or not. Because even if I have a patient with an AHI of 100, but if I can see an anatomically identifiable site for removal, well, I guess I can and I must operate him and not wait as AHI being 100, so I will not operate. The BMI controversy also has been laid to rest, because I guess BMI was more in terms of comorbidities of the patient and how the patient would respond post-operatively. BMI obviously higher, we tend to not want to get into too much, but again, if there is a proper identifiable site and if there is a proper understanding of what you're going to do and the realistic expectations of that particular patient, then BMI should not be a criteria to totally write off. Although it is still globally thought that anything above 35, come up with a little caution and don't go ahead and start doing something for that particular patient. Diagnosing has no longer got any controversies left. We all know that there's a physiologic part and an anatomical part. The anatomical we identify with either clinical evaluation, scopes or imaging, so I won't get into that. But the scopes have definitely made a difference as far as trying to identify with a DICE, a drug-induced sleep endoscopy, as compared to just doing a simple maneuver with the Mullers, or for that matter a maneuver where you try and see just in an awake situation, because what you see in an awake situation versus what will suddenly open up to you when you see an apneic event here suddenly, where you see is totally obstructed, and the next second you'll find that the opening happens and there is nothing below. So we'll just watch that. There you are. So everything down there below looks good. So you obviously know it's a primary epiglottic collapse. So the DICE and the FNLP has really helped a lot for us to be able to identify exactly at what level the obstruction would be, because otherwise you would be looking at it and saying that this was palatal because that was what was fluttering. But when you go down a bit deeper and you wait for the apnea to actually happen, that's when you realize where the primary epiglottic collapse would be. So the controversies for FNLP related were mostly because people said that it was an awake situation, so not really as normal as you wanted. But you must do that along with a cine MRI, so that gives you a complete overall picture of an endoscopic view with the scope and an extrinsic view with the cine MRI. The Mullers has been statistically now proven to show that you can really identify a base of tongue issue with that very well. So you don't necessarily have to just write it off. But the main obstruction to DICE, or the main objections to DICE, were the fact that it was unphysiological because it was drug induced. And so that's where now instead of propofol we're starting to use Dexmed, which gets better. And what happens is now we've started, there's a lot of issues coming up with the physicians who said that when you do DICE, you don't know at what level of sleep are you actually seeing the patient. So for that, what I've started to do now is an intra-procedural PSG. So I'm doing a a drug-induced endoscopy. Along with that, there's a PSG happening simultaneously. So that will tell me in the OT itself as to what level of obstruction I'm going to be, what level of sleep am I seeing, what particular obstruction. So this gets it more accurate, thereby allaying the controversies as to what level of sleep are we trying to find out things about. But a word of caution to all my colleagues who do a pre-operative DICE just before surgery. because medical legal is also my other forte, I need to make this point across that you do not do a pre-operative DICE and then go ahead and continue your surgery after the DICE, because the patient has to give you a self-consent, not a relative consent. Relatives giving you a consent. So the patient has to be informed the findings of your DICE and what you plan to do further, and they have to give you that consent with clear understanding. So if you've already posted a patient for surgery and doing a pre-op DICE, it doesn't work in the court of law, because you've already pre-decided what you're going to do, so the purpose of DICE is lost. So please don't do that. The other issues that were coming up with DICE globally was the fact that we were not able to find the analysis and to quote it properly. So in a DICE, what were you looking at? You were looking at the vertical level of collapse. So you had palate, oropharynx, tongue base, larynx. You had the degree of collapse that you were trying to identify as partial, complete, or probably not seen. But what is happening is, like two of us, if we were to sit across and discuss the results of DICE, how do I communicate with any of you? How do you communicate with me? So what came up was something like the TNM classification is what we got thinking, and we are hoping to publish this internationally also. It's happening that just as a TNM classification, if two oncosurgeons discuss a TNM classification, each one knows exactly what the other is talking about. So in a DICE, you now start the third analysis, which is the type of collapse which could be either anteroposterior, lateral, or concentric. So if I say a V2C, O2L, T2, E2, AP, it becomes more easily specific for my colleagues, or if I'm told something like this, I know exactly what my colleague is dealing with. So we're talking about a concentric complete collapse at the velum, an oropharyngeal lateral collapse complete, a T2 collapse, and an E2 AP. So this is hypothetical, but this is how you actually start giving out the results of a DICE, which again alleviate the reasons for us not being able to give DICE results out properly. Now, I have been the one who's spoken a hell of a lot on cine MRI across the length and breadth of this country, so I will not get into much details. What is now happening is, what I'm trying to do is also try to get volumetric imaging data, which through a CBCT we are able to measure the volumes pre and post-op. Of course, this is a lot of issues because it's again in an awake situation, in a standing up situation, so it's not dynamic enough, which is where the dynamic MRI is what I was always been speaking about. Its core is because it gives you a lot of information about the type of collapse, the level of collapse, and the diameters of collapse. But to put these controversies to rest, I would say that do not write off the CBCT right now, because the CBCT is caution, we are still working on it, men at work. The cine MRI definitely scores a lot over everything else, and the cephalometry again is not to be written off, because any work that you do on a bony cage, you still need the cephalometry to keep getting your dimensions right. So in the end, we come to like the evaluation, which is now very clear. There's no controversies. You have something that is recommended and you have something that is mandatory. So we definitely recommend the level 1 study, which all of you all have to do. But even if you're not able to do a level 1, you do at least a minimum of a level 3, and you do a DICE or a awake FNLP with a cine MRI. So one of these is definitely mandatory. You don't need to really do all of them if you don't have the present machinery. The controversies related to nose, nasopharynx, and palate were always related to, do we do these in a single sitting or not? Should we do them in a single sitting or not? So the times when we were doing a lot of nasal packing, we were definitely recommending that you don't do them all in one sitting, but now there's a general consensus that when you're using, say, nasal splints or using quilting sutures, you can definitely go ahead and do all of these three in one single sitting, keeping all the other variants obviously in place. So there's no controversy now in today's date as far as this is concerned. But there is a very, very big controversy on the palate. This is a major controversy that was happening, now again put to rest, because a lot of y'all who have been either following up OSA or have been seeing all this, you hear so many terms. There is expansion sphincteroplasty, there's lateral pharyngoplasty, there's reconstruction pharyngoplasty, blah, 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 so many things. So what exactly are we doing at the palate? So everything now has changed from the excisional palate work to reconstructive palate work. And by reconstructive palate work, we are talking about only dealing with the palatopharyngeus, because the palatopharyngeus is what is going to expand your palate in the anterolateral directions, and that helps a lot to open up the airspace. So there is again, this controversy has been laid to rest. But the proper selection would not remain just with the selection of the palate. It also remains a lot with the other holistic approach of the patient and his mindset. And we still are having a lot of issues with what do you do with a thick bulky palate, because zeta is not indicated in every one of them, and UP3 obviously evidence-based medicine has written it off. And that's where new fads come in, right? So this is the barb pharyngoplasty, which is a new fad, and I will just go take you through for a little bit of it. Now this is something where the sutures are put in on both sides, and obviously a prerequisite is a tonsillectomy. I'm going to try and give you pictures, endoscopic, nasopharyngeal, and the one oral. So you will be able to see that every time the stitch is taken through, you will see the palate being pulled up, and this is reproduced with permission. So what this does is basically after the tonsillectomy, the entire procedure is related to fixing the palatopharyngeus onto the pterygomandibular raphe, which you see at the corner, which has been marked over here for you. This is the pterygomandibular raphe. So everything eventually has got to be hooked anterolaterally to the, did that stop playing? To the pterygomandibular raphe, and you will see that the whole thing starts expanding. Let me just play this quietly for just a minute. These are very small videos, and there's nothing that I really need to explain to an august gathering like this who's watching, that all we're doing is picking up the palatopharyngeus after a tonsillectomy is done, and we're using the barbed wires on both ends. So it's a simultaneous pull that happens at the end of it when you're pulling it on both sides, and you can see the actual pull happening nasopharyngally, and you will see and appreciate the expansion of the airway there. Right? Now the problem that happens with a barbed pharyngoplasty is that any new fad that we all enter with, we are all very happy to jump the gun and start talking about the results and stuff like that. It's a little too early in the day, let me tell you that. And I will say that because although on table this is the kind of opening that you see, we have no idea about the fibrosis that happens and how long that will hold. And let me just tell you about the gentleman who started this, Professor Vicini, who also thinks like us and says that it's too early in the day for us to really get out with the results. Now the problems, or rather I would say the controversies related to barbed, are the fact that it was started by Vicini about 3 years back, and a lot of other people got into it over the years from the Italian group itself. So Dr. ABC from across the world goes to VCD and picks up these different techniques, comes back to our countries or their respective countries, and then each one starts doing their own ones which they have picked up. And the fact of the matter is surgical work in OSA per se is low. To that you add trying to do a specially indicated patient of barbed pharyngoplasty, which is again a smaller subset, and then each one doing a different technique is again a smaller subset. So everyone lands up getting 8 or 10 cases and wants to jump the gun by trying to present this, because you'll be surprised that when I do a scientific program for OSA, there are requests of n number of people wanting to just show this particular procedure. So even the bigger guns say that we need to collectively get the data, and that's what I've been always propagating across the country, that please share data. It's time to start sharing data in a huge country like ours, where 15 cases per person across the country would amount to maybe 1,000 cases which we can put across as data, even if it is different techniques. So it's too early. There's no controversy in this. Just hold your guns and don't start jumping to results of this particular procedure so soon, because we need to know how long the fibrosis is going to last. A very major topic of controversy was the tongue base, which is no longer a controversy anymore, because we know that we have to deal with some parts of the tongue base, and we identify them as the higher tongue base or the lower tongue base, which has no anatomical demarcation, but it's a visual demarcation when you see it on a vertical segment in a dynamic MRI. So what happens if you have a high tongue base? It's very logical and obvious that you have to enter intraorally, and there you have to either excise it with whatever way you want to use it, or you use a base of tongue radio frequency. But if something lower down, then you need to go through the neck somewhere externally and try to pull that lower tongue base up forward. So high and low controversies have been laid to rest, but again, a lot of these decisions would depend on the informed consent from the patient as to whether he knows what is being done, whether he is okay with it and is willing to go ahead with it, because it's not your risk-taking ability, it's the patient's risk-taking ability that actually comes into play here. So the controversies here are way too simple now to really get into too much details. The other controversy that you face across the world, rather not just the country, is the PAP versus surgery. They keep saying PAP, 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 we keep saying surgery, surgery, surgery. And now, even at any chest forum that I'm invited to, they are very clear and they've understood this fact that their PAP results, PAP failures in compliance on long terms, they themselves have documented it as low as 40 to 50%. So if my surgery, which was initially probably 60-70% success, over a few years with fibrosis goes down to 40-50, that is as good as their CPAP failures over a few years. So I guess now we are poised at a stage where if we know what we are doing and where we are getting to, then probably we don't have to back out from the CPAP version of treating this particular thing. The pediatric controversies are there. We are all doing a lot of tonsilloadenoids with coblation, but the biggest question that comes in is, when you have a child who has been diagnosed with an adenoid, probably lesser airway, but is non-comorbid, then do you really want to go ahead and treat this child? If there is no comorbidity to the patient, does this need to be really attended to? But yes, the meta-analysis and the literature clearly shows that there is expected to be an age which is yet to be demarcated, beyond which neurological issues may be irreversible. So if you do attack it as early as possible, you will get a better result definitely. No controversies with any of this, but a major issue of discussion would be whether we want to do it single stage multi-level versus single level multi-staged. And now this controversy is not a controversy because the choice of procedure is individualistic with the operating surgeon and the patient concerned, and your criteria for making the choices would be the education of the patient, his motivation, more importantly follow-up issues. In an era of medical tourism where we have a lot of our patients coming in from outside the world and they come to you for your country for maybe 8 or 10 days, he's not going to keep coming back to you again and again for treatment. So you may probably have to attend to that with a single staged multi-level surgery. And that would all depend on what you come out of the particular evaluations. But again, like I said, the choice of procedure would remain mainly on your backups, your level of expertise, what kind of risk the patient is willing to take. So these are very important things when you consider picking up a patient for surgery. So what do I see the future of this in India? I think like Dr. Divya Prabhat said, even 10 years back when I made the first presentation, the last slide was always future and it showed hypoglossal stimulators. 10 years down the line and having roamed wherever possible, the last slide still remains hypoglossal stimulators and future in India. So that means this thing is really not, it's just for academic discussions. It's probably not taken up for various reasons, maybe because 10 years is a pretty long time and something comes up and has not moved forward. But we need to do research on different types of procedures and what their results are before we can actually go ahead and do something about it. And my dear colleagues would probably agree with me when I say that now our goal no longer remains AHI. It's a kind of a holistic approach where you have a happy and safe patient, more importantly the bed partner, which in today's date is not necessarily the spouse, neither is it a person from the opposite sex at most of the times. So you've got to be more realistic about the entire issue. You've got to take care of your entire partial and non-improvements. And the next few slides, I may ruffle a few feathers, but purely unintentional, and this presentation is just to stimulate a lot of thinking, so please bear with me on that. So when I'm doing something like this, why am I doing this? Am I doing this just to go up on the stage to a chest physician audience and tell them, listen, this is what you gave me as an obstruction, and I've cleared the obstruction and I've come to you to tell you that I can tell you exactly where the dice is. Is that what I'm doing it for? Because if I'm doing so much, or if we are all going to get into doing in intra-procedural PSGs, it should improve our understanding of the pathophysiology. And hence, it should make a difference to our results. And if it is not making that, then I guess what we are doing is pretty useless to go ahead and do all this, because we really don't know what's happening where. Does playing around with the palatopharyngeus and the genioglossus muscle, is that really making a difference to our outcomes of surgery? Because everything that we seem to be doing is eventually attacking the tongue base and it's attacking the palatopharyngeus. So all this, does it make sense? Are we on the same page with following the standard operating protocols? Because most of us generally are not. Each one is an individualistic thinking about what to do. And unless you understand that as sleep surgeons, we are still dealing only with the obstructive part of the OSA and not about the rest of it, then I guess we won't understand what we are going to be doing and how to improve our results. your attitude would be defining your results. So if you are an ENT surgeon, the answer to you handling a pure SN loss is probably what will answer to you about a complete sleep specialist, because if you're not going to touch that patient of SN loss, you're not treating him completely. And my parting thoughts would be the standard operating protocol now, which becomes very important, where you remove the surgeon variable. You cannot remove a patient variable. You've got to remove the surgeon variables so that you are having a standard protocol which will help you across the country and across the globe to be able to get a holistic treatment to OSA and remove all the controversies that come purely because of surgeon variables. So I would like to end with a very simple thought process where you don't just learn the facts, but you train your mind to think about it. Ashish and me were co-faculty with Samir for a lot of FES workshops many years back, and one of the things that I've picked up from Ashish is to write my own obituary while I'm alive. And I don't think I have really much to write about, except for the fact that maybe I came in, did my bit, and I'm trying to get people to train their mind to think rather than go for exactly like what Deepak said, the glamour aside and what is actually on the ground level. And I would end it with just 20 seconds of few lines which probably sum up my philosophy of life, because this is what I believe in. मुझसे बेहतर कहने वाले, तुमसे बेहतर सुनने वाले, कल कोई मुझको याद करे, क्यों कोई मुझको याद करे, मसरूफ ज़माना मेरे लिए क्यों वक्त अपना बर्बाद करे, मैं पल दो पल का शायर हूँ. Thank you.